Lower abdominal disorders. We are, before you guys go off to dinner, it's the last talk of the day, we're going to take a little journey through the lower colon together. All right, so let's start off with a big differential. I'm not going to go through all of this. This is just a general approach, kind of a reference slide, again, for a quadrant-based approach to differential diagnosis, right upper, left lower, right lower. We are going to focus today on the right lower quadrant, left lower quadrant. But just a couple of points here. One, when you look through this differential, it is a huge spectrum of different types of disease states, and they can range from being very, very benign to very dangerous. It's important for us to be able to diagnose the dangerous things, which is what we're going to focus on today. One note of caution about gastroenteritis. This may have come up already in the conference, but if it hasn't, it bears repeating. Writing the words gastroenteritis on a chart should always make you think twice, am I missing something more important than gastroenteritis? The first problem with gastroenteritis is gastroenteritis means what? Inflammation of the gastric and of the intestines, gastroenteritis. I don't, when I'm in the emergency department, carry around a colonoscope and an endoscope, so I don't actually know if they have inflamed stomach and inflamed bowels. So the first problem is being accurate with what we're saying. I typically write something like vomiting and diarrhea because I know that to be true. I don't actually know if gastroenteritis is the actual diagnosis they have. The second problem with gastroenteritis is that it oftentimes is the diagnosis that we write when we're missing other things like appendicitis or other life-threatening diseases. So just always have that in the back of your mind when you're about to write that diagnosis. Make sure that and it may very well be exactly what they have, but make sure that you're giving the patient really good return instructions to make sure they don't have the other bad things if things are getting worse. Okay, first pitfall diagnosis, constipation. We see a ton of this in the ED. Patients come in, they're saying, I haven't moved my bowels for 3, 4, 5 days, especially in elderly patients. Now, I want you guys to, especially in this old elderly, I don't say, my folks now are sort of in their 70s. They're like old as whatever I am plus 10 years. But let's say elderly defined as 65 years and older. In that patient cohort, what is the mortality of patients presenting to the ED with abdominal pain? Is it the same as MI, worse than MI? It turns out it's about 10%. Pretty high mortality for patients that are coming in with abdominal pain in the elderly patient population. If they happen to have if they attribute their pain to constipation, fine. But if they have concomitant abdominal pain or a tender abdominal exam, it's worth thinking, gosh, am I missing something more than just constipation? But oftentimes, it is actually constipation. What do we do? So the first thing in the elderly patients, say they don't have any belly pain, it sounds like it actually is just constipation. One of the most common reasons for that is that they have a fecal impaction. Nothing will make you feel more like an ER doctor and remind you more why you got into this specialty than to gown up and do a fecal disimpaction for a patient. Has anyone had to do one? Yeah. I mean, it is great for the patient that's had that stool ball in there, but you have to, there's a line in here. Consider taking a patient to a standard private room in the hospital with a toilet. I could not agree more. If you have mismanaged doing this fecal disimpaction, there are times where you do such a good job that it literally is a river that will back up right behind that. So you want to make sure that you're fully gowned up, you're fully protected, that there's a place for the patient to go to immediately after that disimpaction is relieved. And then, again, just make sure that we're not missing other diagnoses. There is a subset of patients that get a fecal impaction, and that actually can be a life-threatening thing. If you've ever heard of the diagnosis stercoral colitis, that is a fecal impaction at the level of the rectum that subsequently balloons up the rectum and can cause severe inflammation and even perf in some patients. So just consider that as well for people that have had long-standing. Otherwise, I don't tend to image my simple constipations, but if it's complicated or complicated by abdominal pain, consider imaging. All right, let's move from constipation to diarrhea. Cha-cha-cha. So diarrhea, what are the 3 major types of diarrhea that we are going to be seeing in the emergency department? There are mostly infectious, and the 3 major categories are viral, and then bacterial, invasive, bacterial toxigenic, and they all present a little bit different. So we'll kind of classify how they may look to help you kind of figure out which one we're dealing with. The most common by far are the virals, the norovirus, the rotavirus, the adenovirus. Probably everybody working in an ED has ordered some food where everybody in the ED ordered, everybody was happy, and then all of a sudden in the next 2 days, everybody was unhappy. And it only tends to happen amongst healthcare workers where everyone's getting sick at the same time, so it really messes with call schedules and everything else. We've had multiple episodes where like every resident in the same class has the same viral thing going on, or every attending. It's really not pleasant. But the virals tend to have a little bit of a prodrome, and then like watery diarrhea. They don't tend to be bloody. They don't tend to have fevers. They don't seem to look toxic, unlike the bacterial invasives that can look a little bit worse. So these patients also have a prodrome. They feel a little uneasy. You go to the wrong Vegas buffet, you feel uneasy for a couple of, maybe a day or so, and then all of a sudden you're having this watery diarrhea, maybe some vomiting, things like that. But it can also present with having blood in the stool. You can have fevers. And here's some of the bacteria that can be responsible for that. Campylobacter. I had a friend, a colleague in medical school who went to India, got Campylobacter, came back, had all the symptoms, the prodrome, had the invasive bloody diarrhea, came back and then actually developed Guillain-Barré. And he had to take a leave of absence from his medical school because he had all of the symptoms of Guillain-Barré for a while. So associated with that, Shigella, the big association there is if you see a small child with seizures, that's something to consider. Salmonella, people with pet turtles, amphibians, things like that. That's associated with salmonella, contaminated food, poultry, things like that. So that's the invasive. They get the bloody. They tend to have the prodrome. The toxigenic, there's no warning. These are the ones that if you've ever been traveling around internationally, you are like hypothetically, you're in a crowded train somewhere, and all of a sudden, in this crowded train, out of nowhere, you just feel like, uh-oh. That is toxigenic, and that is associated with traveler's diarrhea. In locally, domestically, that would be associated with you're at a picnic, they have some like potato salad with mayonnaise or like cream puffs or things like that have been sitting out in the sun, and those like cream puff mayonnaise-y type things get infected, and then all of a sudden you get that sudden onset of watery diarrhea, non-bloody. Why is it sudden onset? Because the toxins are preformed. There's these exotoxins, as in like staph, E. coli, and then those exotoxins cause you to have severe diarrhea. So what do we do in terms of treatment? A lot of this has to do with getting the right history and then trying to tailor that to how am I going to treat this person. The vast majority of these diarrheal illnesses, it's a matter of rehydration. If they're having nausea or vomiting, give them some Zofran, maybe some Pepto-Bismol. Remember, Pepto-Bismol in young children, avoid. Why? It has bismuth salicylate, so you don't want to be given like aspirin-like products to young kids. That's why we don't give Pepto-Bismol for the really, really young kids. It's okay to give in adults. But who do we actually treat with antibiotics? It really is like the cohort of patients that are prolonged symptoms or they look really toxic and febrile. And remember, there's a subset of patients that get E. coli, the 0157H7 variant, and then there is a theoretical risk with that if you give them antibiotics, they get worse. That like the kids can develop HUS. So my general approach to these is unless they look awful, unless they're like really febrile and toxic and looking terrible, I avoid antibiotics. I'll send off the cultures. You get the stool WBCs, send the cultures, C. diff, all that kind of stuff if they look bad, and then have them follow up. I don't get cultures on everybody, but just the ones that are like looking worse than neurotypical. Most patients, I'll, supportive care, outpatient. Most do fine. If they have that traveler's diarrhea, you can give them some Cipro and some loperamide. All right. Oh, did I skip a C. diff? Okay. So C. diff is becoming more and more prevalent as the years go by. We're seeing it more and more as we are giving more antibiotics in the healthcare settings. C. diff is a normal part of our gut flora. However, when we're giving antibiotics, they start to kind of proliferate and can cause problems. So the big risk factors, who gets C. diff? Number one, patients who are on antibiotics, usually 7 to 10 days after antibiotics are started. Clindamycin, Augmentin, those types of patients can develop it. Healthcare workers, all of us. All of us are at risk for C. diff if we're not taking proper hand washing precautions. Is it enough with, you see a patient with C. diff to go and like squeeze that little alcohol thing? No. You have to really, they have spores. They're like little cockroaches that are impossible to kill unless you really like wash your hands with soap and water, and you have to scrub those spores off. So healthcare workers, antibiotic use, and then just being over 65 makes you an independent risk for getting C. diff. Now, if somebody is having significant diarrhea and like really, really profuse diarrhea after having any of these risk factors, you may want to start thinking about C. diff, especially if they have fevers, if they have distended belly, then they can get fulminant colitis from that as well. So you would send off a C. diff PCR. The problem with the C. diff PCR is you can't tell, are they colonized with C. diff, somebody who has C. diff, who's had C. diff for a while, or do they have active C. diff? So you really want to only order these tests in the setting of true symptoms, because there are some false positives. Now, what's the treatment? It used to be that the treatment was metronidazole or Flagyl. The recommendations have changed. There's been increasing resistance to that. So now the treatment recommendations by the IDSA are to give oral vancomycin. So that's been a change over the past few years. Here's the dosing regimens here for you. Another thing to consider is if a patient has had C. diff, they've gotten oral vancomycin, and they've failed, and they're now back with recurrent disease, there are tapering longer doses that you may need to give, but there's IDSA guidelines. So just look it up. Whenever somebody has C. diff, known C. diff, first time, give them oral vanco. If it's recurrent disease, look up the recommendations for the longer tapered dose. And then obviously if they're in shock, they're being admitted, they have fulminant colitis, they're at risk of perf and all that stuff, then they get their vanco and they get IV Flagyl or metronidazole, and they get admitted. Hand hygiene, we had talked about that. Just make sure that you wash your hands really well. Contact precautions, that's why you gown up, why you glove up, and you do really good hand washing so we don't spread it to each other. All right, let's shift gears, move over to appendicitis. Appendicitis, classic. I have periumbilical pain. 12 to 24 hours later, it migrates down into the right lower quadrant. Why does it happen? For the majority of patients, it's because they have fecaliths in this little vestigial organ that should never have existed in the first place. Human body was pretty well designed. There are some flaws. This is one of the flaws. So what is the classic history? It's that you have periumbilical pain that goes down to the right lower quadrant within 12 to 24 hours. If you have that history, that is the single strongest predictor that a patient actually has appendicitis. Okay? However, that history doesn't exist in most people. Less than 50% of people will give you that classic story of periumbilical, right lower quadrant, I'm also nauseous, and I haven't been able to eat anything. That is not happening in most people. Who doesn't read the textbooks more than anybody? Little kids and elderly. They're really stubborn with the diagnosis. They don't read the textbook. They don't present the way you wish they would present. They can present with sort of all sorts of vague symptoms. So have your antenna up, especially when it comes to younger kids and for older adults. Now, one thing that is pretty classic for most people is that they will have abdominal tenderness, either diffusely, because remember, it starts out as a visceral type of pain, nonspecific. The appendix gets inflamed and it causes this visceral, diffuse, nonspecific pain. As the inflammation gets worse, it turns into a somatic pain, different nerve fibers that then help you to localize it. But most people will have some level of abdominal tenderness, even better if it's in the right lower quadrant. Now, in children, some of the things that could be tricky. Number one, you can see here that the perforation rates are pretty low in adolescents. In young kids, almost all these kids are at high risk for perforation. And then they come in with all these like other features that confuse us. They come in with diarrhea, they come in with constipation, they have some dysuria. These are confusing symptoms that make you think acute gastroenteritis, UTI, other types of things. However, always be careful to not kind of anchor on other things if they have that right lower quadrant tenderness. In dysuria, one of the things that can happen if you get a UA, and that UA shows a ton of white cells, but no bacteria, That's concerning, right? Like though, in a typical UTI, you should have bacteria and white cells. If there's no bacteria in there, that may be indicative of a sterile leukorrhea, which it means that there could be like part of the appendix is inflamed and pushing on the ureter, causing that type of picture. Lots of potential misdiagnoses. Be really, really careful. My biggest takeaway for the potential for appendicitis, we're not scanning every single child that comes in with potential appendicitis, nor should we. However, when there's a potential for appendicitis, if we're not going to do the entire workup, we should give the parents really, really good return instructions that if the pain is worsening, if anything is changing, come right back, and at that point, we'll continue the workup. So what are the imaging choices that we have for appendicitis? They're multiple, but more and more, especially in the young children, we are moving toward ultrasound as a potential type of imaging. It's not the most sensitive. However, if it's positive, then it avoids you having to do all the other stuff. Like think about in a young kid. A, you don't want to give them a CT scan because that's a lot of radiation. B, getting a little kid into an MRI machine, man, that's not fun either. So if we can get them in for an ultrasound and we can pick up that appendicitis in there, really I've worked in a bunch of different EDs. The ED I work out at the county in Los Angeles, man, the techs are great. They pick up appendicitis on those ultrasounds, or they'll see the appendix and tell you that I can see the appendix, but it doesn't look inflamed. There's other places where I know what the read's gonna be every single time. Unable to identify the appendix, every time. And so it is very much like operator dependent, and you got to know what your local practices are. But ultrasound can be a nice first imaging modality. Now, if that's not an option, in adults, CAT scan is totally fine. CAT scan with IV contrast. They don't need the oral. They don't need that triple contrast. I used to work at a place where the radiologist insisted that every patient get this triple contrast thing. Give them oral, and then make sure they get the rectal contrast as well. And I'm like, man, first of all, it's not backed by any evidence that giving rectal contrast is helpful for these people. And I would tell the radiologist, if you came to our ED and you would want us to shove a rectal tube in and give you rectal contrast, I'm happy to do it for the patients. But I know you wouldn't be, and I'm not doing it for the patients either. It's totally fine to just do IV contrast for these patients. And if you don't have IV contrast, the sensitivity is still pretty good without that. MRI, I use for young children, or for children, period, and pregnant patients. MRI is a good diagnostic modality and picks up the appendicitis most of the time. All right, so what do we do? How do we manage it? Operation, right? Slam dunk? Not always. So I feel like this is one of those great scenarios where shared decision-making can help quite a bit. You are, as a matter of routine in the emergency department, going to be admitting these patients and talking to a surgeon. It is not unreasonable for the surgeon to offer the patient a course of antibiotics rather than immediate surgery. Why? They can get better with the antibiotics, although there are higher rates of recurrence with antibiotics. But if a surgeon comes down and tells you, hey, we're just going to do antibiotics, we're not going to take them to surgery, that's not a totally unreasonable thing. Does anybody remember Rafael Nadal? There was the Shanghai Open, famous tennis player. He was in the middle of the Shanghai Open. He developed appendicitis. He ended up going to see the doctor, and the doctor said, hey, you have appendicitis, like you should get surgery. They ended up actually opting for antibiotics so that he could play through the Shanghai Open. He got his butt kicked in the next match, but he wanted to play, he played. And there may be scenarios, gosh, you're visiting family, out of state. You go to the hospital. You have all this kind of stuff to do back home. Maybe that's a scenario where you would want to get antibiotics and then go back and then get surgery later on. But more options for patients, always better thing. Let's switch from the right lower quadrant to the left lower quadrant. Diverticulitis, very common in the elderly, becoming more and more common in young patients, especially with our Western diets. You have these diverticuli in your intestines, these little pouches in the colon. If you have like seeds or something, it can get like infected in there and inflamed. And mostly on the left side, those are the ones that get inflamed. Then you have a left lower quadrant pain, and you may develop diverticulitis. The question with diverticulitis is, how do we treat this? Oftentimes, patients will have a history of diverticulitis. Hey, I've had diverticulitis before, I'm coming back, I have the same left lower quadrant pain. I don't CT all those people, but if the patient's febrile, they're looking worse, they have a lot of pain, it's worth scanning those patients, make sure they don't have complications like perforations, abscess, and all that kind of stuff. Now, once you've diagnosed diverticulitis or a complication of diverticulitis, then we have traditionally antibiosed all these patients. Okay? Some of them can go home if they look good. Some of them need to be admitted if they have complications or look pretty bad. But more and more evidence is coming out that, in fact, maybe diverticulitis is not an infectious process all the time. Maybe it is an inflammatory process, and these patients can get just NSAIDs. It depends on your local practice. I wouldn't start going out and just giving everybody NSAIDs and sending them home. But just recognize that there are more and more places in Europe that have gone toward like doing outpatient management with NSAIDs. The outcomes seem to be pretty good compared to giving antibiotics with less side effects from the antibiotics. For the meantime, for me, I'm still giving the antibiotics whether I'm doing outpatient or inpatient, but there is a trend and a movement toward potentially just giving anti-inflammatories for these patients. All right. We're going to move from the diverticulitis and appendicitis to volvulus. Now, this is a type of bowel obstruction, a closed-loop bowel obstruction in the large bowel, the sigmoid volvulus. There's two types of volvulus that you all should be familiar with. There's sigmoid volvulus and there's cecal volvulus. And although they're both sort of some sort of closed-loop bowel obstruction that can twist upon itself, they present in two very different populations, and they have two very different types of treatment. So let's start with sigmoid volvulus. This tends to happen, sigmoid senile, happens in the more elderly patient. And the way that this presents is typically in elderly patients that are chronically constipated. Think of like a nursing home type patient that over time starts developing worsening pain and can't poop, maybe is vomiting, maybe is having worsening abdominal pain. You get a CT or an X-ray and you get this big dilated loop of bowel. The treatment for these is you consult surgery, and it happens down in the sigmoid colon, which is close to the rectum. They can get a sigmoidoscopy and actually get that thing fixed with sigmoidoscopy with a minimally invasive, less invasive than open surgery. If that doesn't work, they'd have to do open. But the way these look on the X-ray, so if you don't have CT scan where you're at, you get an X-ray. They call it the bent U-tube, the tube pattern, inner tube pattern. It goes from the left upper quadrant down to the right upper quadrant down to the left lower quadrant, as you can see here. It's a bent inner tube, big loop of large bowel. That's a sigmoid volvulus in the right patient population. Versus the cecal volvulus, you think about the younger patient. You hear often like the patient presentation of a young person running a marathon. All of a sudden they get this boom, abrupt, sudden onset abdominal pain. You push, they're sort of like distended, having pain. You get the X-ray and you see a big loop of bowel, similar to what we just saw, but it's a little bit different. The cecum tends to be higher up in the bowel, and so it looks more like this. You don't see it down near the rectum. It's up in either the right upper, left upper quadrant, and it looks more like a kidney bean or a coffee bean, like this type of appearance. These patients, unlike a sigmoid volvulus, they can't get a sigmoidoscopy. Why? It's more proximal. You couldn't snake it all the way up there, so these patients actually have to get open surgery. All right. Let's shift gears to Crohn's disease, inflammatory bowel disease. There's Crohn's disease, there's ulcerative colitis. A lot of similarities between the two. These tend to be like either youngish patients, they kind of have bimodal distribution, or like in their 50s, that have inflammatory bowel symptoms. They'll have abdominal pain. They may have like increasing diarrhea. And then they may also have sort of extra-intestinal manifestations. They might have joint pains, arthralgias, dermatologic stuff. They may have uveitis. If you see that constellation of stuff, think Crohn's, think ulcerative colitis. Crohn's happens all over the bowel, and they can get like skip lesions and all that kind of stuff. They can get bloody diarrhea, but it's less common than in ulcerative colitis. And then they can get all sorts of complications. If you get a Crohn's patient who's having severe abdominal pain, generally you want to get some imaging on those patients. They can get all sorts of complications there. They also have an association with kidney stones. So the treatment for Crohn's disease, let me just go back here, is generally getting them on some sort of steroids. They tend to be on immunosuppressants or other medications to control their Crohn's if they're known. If not, then if they're a Crohn's flare, then a lot of these patients, you'll talk to the rheumatologist. If they're having a lot of bowel movements like diarrhea, fevers, things like that, they generally will get admitted for control of their Crohn's flare. If it's really mild, they might be able to get treated as outpatients. Ulcerative colitis, on the other hand, like Crohn's, has inflammatory features. They can get bloody diarrhea, but they get bloody diarrhea at a far higher rate than the Crohn's patients. They have high rates of cancer, and they can look a little bit sicker when they're having their complications. They tend to only have it in the lower part of the bowels, like near the rectum. But again, same kind of thing. If they're having a lot of bloody stools, fevers, they're having an ulcerative colitis flare, they get admitted, they get steroids, and they get treated. If it's really mild, you talk to their GI or rheumatologist, and a lot of times they'll get outpatient treatment. Small bowel obstruction. Two most common causes. The first most common is they've had a surgical scar. You see anybody with a surgical scar in your ED with abdominal pain, you should be thinking small bowel obstruction. They get adhesions. The second most common, if they don't have a history of surgery, is looking for some hernia, some incarcerated hernia that we're missing. So you really want to investigate, if you're not seeing a scar, somebody that you're worried about a small bowel obstruction. They're distended, they're having abdominal pain, they're vomiting, they haven't pooped. Think about looking for hernias as another cause. Cancers are also possible, but like a lot more rare. X-rays, you can see dilated loops of bowels, but CT is really the imaging modality of choice, and you can see right here some air fluid levels. If you get an X-ray and you get more than one air fluid level in the same loop of bowel, that is concerning for a small bowel obstruction. You can see the same type of thing on this X-ray, and then on the CT, you'll just see the same air fluid level. But with the CT, you can see where that inflection point is, where they got the small bowel obstruction. It's good for GI to know. In general, we give these people IV fluids, analgesics. If they're actively vomiting, then an NG tube is warranted as well. Although I'll tell you, most surgeons want an NG tube regardless for most of these cases. I tend to give it only to the patients that are actively vomiting, and then the surgeon can have the discussion about like shoving that NG tube in, because it is a pretty painful procedure. Large bowel obstruction. Lower down, we already talked about cecal and sigmoid volvulus that are sort of some form of a large bowel obstruction, but a large bowel obstruction doesn't happen as sudden onset as a small bowel obstruction. The major cause of large bowel obstruction, malignancy. We talked about that's sort of a rare cause for small bowel, but for large bowel, that is the majority of the cases. They can also get volvulus intussusception and all that. The clinical diagnosis, again, they're distended, they're having abdominal pain. A lot of them will have on their x-rays something different than a large bowel obstruction. You'll get a big dilated loop of bowel that's more in the periphery. Small bowel obstructions you tend to see more in the center. Large bowel obstructions you see more in the periphery. And then it's just bigger. Small bowel obstructions tend to have about a 3 centimeter dilation, whereas the large bowel tends to be 6 to 9 or larger. Okay, mesenteric ischemia. In emergency medicine, if anybody ever asks you, what is the worst thing this person could possibly have for, and fill in the blank, headache, chest pain, abdominal pain, anytime you say something vascular, you're usually right. And so for abdominal pain, if I ask you what's the worst thing somebody could have, it's generally like, what's a ruptured AAA? That would be the worst. The other thing is lack of oxygen or lack of arterial blood flow. So abdominal angina, which is mesenteric ischemia. You're not getting enough arterial flow to your intestines. This can be a really problematic diagnosis. Who gets this? Patients that have AFib. Patients that have low flow states, they're on pressors, they're getting treated for sepsis, things like that. So anything that would decrease the blood flow to the intestine is concerning for mesenteric ischemia. Think about a patient. The classic patient would be a patient with AFib who's sitting down eating a meal, and all of a sudden, as they're like starting to eat, they get this abdominal angina. That is mesenteric ischemia until proven otherwise. And pain out of proportion to exam. You're getting the exam and they're not that tender, but then they're telling you their pain is like extreme. That's concerning for mesenteric ischemia. So think about it particularly in older patients or patients that have AFib and those types of things. oftentimes they can get really high lactates and really high white counts. They don't need to have that. If you have a really high clinical suspicion, you'd still scan them. But if they have really high white counts, really high lactates in the right setting, consider this diagnosis. The treatment ultimately is surgery or IR, where they can go in and embolize a vessel or open up the vessels. Okay, hernias, we're almost down to the home stretch. What you need to know about hernias is they can present in 3 different ways. The most common way is that they're reducible hernias, and the majority of them, more than 90%, are inguinal. You push on it, or you get them in Trendelenburg, you ice it, you give them a little bit of pain meds, you come back in 20 minutes, you push that puppy right back in. Those patients are okay. But if they're incarcerated or they're strangulated, those patients need a surgical consult. Incarcerated means that the hernia is out and we can't get it back in. When they're strangulated, the hernia is out, we can't get it back in, but they're also not getting oxygen into that hernia site. And so they are strangulating. They're going to have pain. You might see some erythema. Those cases, oftentimes, you may even bypass imaging, call the surgeon and say, I'm worried about a strangulated hernia. This needs to go right away. For the incarcerated hernias, oftentimes you have time to image and talk to surgery. One comment about femoral hernias. These happen largely in females. Inguinal hernias are the most common, both in men and women. But if you get a femoral hernia, that is more likely to happen in a female, and a lot of these can present on their first presentation as incarcerated or strangulated. All right, perfed bowel, most common cause by far, perf viscus up, like due to an ulcer, up high, but you can also get perfed bowel down low in patients with diverticulitis or appendicitis. So if you're worried about perf viscus from an ulcer, you can get an upright chest x-ray or a lateral decube, and you might be able to see some free air. You're not going to see that with perfed appendicitis or perfed diverticulitis. Perfed viscus from an ulcer, they tend to have severe pain. Perfed viscus from like appendicitis, sometimes they'll have a lot of pain, and then they'll perf and they'll feel a lot better all of a sudden. Any perf requires a surgical consult. Here's a couple of images here. So here on the chest x-ray, you can see a perfed viscus from what is likely an ulcer, and you can see that little pocket of air right below the diaphragm. That is a perfed viscus likely from an ulcer. Same thing that you see here. And then you can see free air on a CT scan as well, either up high or down low. All of these require surgical consultation, admission to the hospital. I believe we have now completed the journey through the bowel.